Hello, my name is Anna Riley, and today we'll be learning about hypertensive disorders of pregnancy, specifically chronic hypertension, gestational hypertension, preeclampsia or eclampsia, and finally, chronic hypertension with superimposed preeclampsia. Hypertensive disorders of pregnancy complicate anywhere between 12 and 22% of pregnancies, making them essential knowledge for any nurse who wants to practice in women's health or obstetric nursing. By the end of this lesson, you should be able to discuss the prevalence of these hypertensive disorders in pregnancy, as well as some of their causes. You should be able to identify the clinical signs and symptoms of these disorders. And finally, you should understand the pharmacological and non-pharmacological treatments for these disorders, as well as what can be done when a woman is planning to become pregnant in order to promote her health and hopefully help to decrease the occurrence of these disorders in the first place. The variation on the previous slide in the rates can largely be accounted for by differences in population demographics from one place to another. For example, certain risk factors put different groups of women at higher risk compared to others. Factors such as primiparous status, or women having their first baby, women of advanced maternal age, or 35 years or above, and women of different ethnic or racial groups. These are all women who are at greater risk of developing hypertensive disorders of pregnancy. So any population that has higher percentages of any of these groups will be likely to have higher incidence of HDPs. Unfortunately, HDPs have only been increasing in the United States. In fact, they've increased 25% in recent years in the United States. This is a severe problem because hypertensive disorders of pregnancy and cerebrovascular accidents, which frequently are caused by severely high blood pressures due to these disorders. These two disorders together account for more than 16% of maternal mortality. And then on top of that, they also impact the fetus or the neonate with severe mortality rates as well as morbidity. These are due to factors such as uteroplacental insufficiency, intrauterine growth restriction, or the necessity for preterm induction of labor or preterm C-section in order to treat the high blood pressures in the woman. It's also important to remember that while the rates of maternal mortality due to these disorders are quite high, the rates of morbidity are even higher, because for every one woman who dies due to these disorders, there are 50 to 100 women who experience near misses, meaning that those 50 to 100 women experience severe morbidity related to these disorders. Let's talk now about the pathophysiology underlying some of these hypertensive disorders. First is chronic hypertension. A woman who comes in for prenatal care with a known diagnosis of chronic hypertension would then be managed accordingly. Unfortunately, not every woman comes in for prenatal care. So a woman who comes in for her first prenatal appointment after conception, before 20 weeks of gestation, if she has multiple blood pressures of 140/90 or above, then it's suspect that she does have chronic hypertension. Another case that we might diagnose chronic hypertension is when a woman first presents for prenatal care between 16 and 20 weeks of gestation. In this time range, if a woman has blood pressures of 130/80 or above, it's quite suspect that she has chronic hypertension due to the normal decrease in blood pressure that happens during the second trimester. And finally, if a woman experiences elevated blood pressures during pregnancy, but continues to experience them beyond 12 weeks postpartum, that woman would likely be diagnosed with chronic hypertension as well. Now, chronic hypertension has a number of underlying causes that are really the purview of another presentation, but the basics are that chronic hypertension is caused by increased cardiac output or increased vascular resistance, or some combination of the two. When hypertension of 140/90 or above presents after 20 weeks of gestation and before 12 weeks postpartum, it is diagnosed as gestational hypertension, so long as it doesn't also include the clinical signs and symptoms that come along with preeclampsia, which we will discuss in the next several slides. Women with gestational hypertension are closely monitored because 15 to 25% of them will go on to develop preeclampsia later in pregnancy. Unfortunately, the causes of gestational hypertension are poorly understood. There are two schools of thought, however. The first argues that it is simply a woman's inability to continue to tolerate the increased blood flow of pregnancy due to hormonal imbalances or under pre-existing conditions such as chronic hypertension or chronic cardiac issues. The second school of thought argues that gestational hypertension is simply a precursor of preeclampsia and will develop into preeclampsia for any woman were they to continue their pregnancy long enough. Unfortunately, many women develop gestational hypertension near the end of their pregnancy, and so it is impossible to prove or disprove this theory. A woman who meets the diagnostic criteria for gestational hypertension and then also presents with one or more of the following symptoms will then receive a diagnosis of preeclampsia. In order to reach a diagnosis of preeclampsia without severe features, the woman must have proteinuria, which is defined as 300 milligrams or more of protein in a 24-hour urine sample, or a protein to creatinine ratio of 0.3 or above. If a woman also manifests symptoms of end organ involvement, such as those listed on the chart here, a blood pressure of 160s over 110s or above, in these cases, she would be diagnosed with preeclampsia with severe features. Other subclasses of diagnoses also fall into this category, such as eclampsia, which is diagnosed when preeclampsia progresses to the point that the woman has a seizure. Another subset in this category is HELP syndrome. HELP stands for hemolysis, elevated liver enzymes, and low platelets. Any of these subcategories fall under the diagnosis of preeclampsia with severe features. Now, the key to understanding preeclampsia really lies in the placenta. So, in a normal placenta, as seen in the upper right corner, the fetal cytotrophoblastic cells, which are a type of stem cell, they invade into the decidua and the muscle layers of the uterus, and they even affect the nerves in that area. The end result is that the spiral arteries there are reformed. Instead of being thick-walled, they become thin-walled, they expand, and so there is a low pressure, very adequate, rich blood supply, and thus oxygen supply to the placenta and to the fetus. Now, in a preeclamptic placenta, those cytotrophoblastic cells do not differentiate appropriately for whatever reason, which is poorly understood. So they don't invade as deeply. So those spiral arteries remain thick-walled, they remain vasoconstricted, which results in a high pressure, low blood supply to the placenta and thus to the fetus. So from there, that hypoperfusion leads to ischemia in the placenta. So that ischemia really sets off a cascade in the rest of the body. First, the body recognizes the decreased blood supply and oxygen supply to the fetus. So it signals vasoconstriction in the rest of the body in order to increase blood pressure and increase oxygen supply to the fetus. Thus, the high blood pressure begins. But on top of that, the ischemia from the placenta triggers chemicals to be released throughout the body that trigger endothelial dysfunction. So the result of all these together causes CNS problems, causes kidney and liver problems, causes edema. It also can cause endothelial dysfunction within the blood vessels themselves. So that triggers things like platelet issues, and it also can trigger hemolysis. For a woman that develops hypertension, it is essential to monitor her for signs and symptoms of preeclampsia with severe features. Here are some examples of some of those severe features: visual changes, new headaches, especially headaches that won't go away with treatment by medication, seizures, pain in the right upper quadrant or epigastric pain that can't really be explained, and that can include nausea and vomiting, or it can present without any nausea or vomiting. systolic blood pressures of 160 or higher, and or diastolic blood pressures of 110 or higher. Unexplained pulmonary edema. Elevated liver function tests. 2 times the normal is diagnostic. A platelet count of less than 100,000, or a serum creatinine level greater than 1.1, or a creatinine level that is doubled from the baseline. Because of these labs that are often diagnostic using baseline levels, it's essential to establish a baseline early in care and to trend levels over time to get a better idea of how a disease process is progressing for a woman. Preeclampsia with severe features can have devastating effects. So it is essential to nursing care to understand these signs and symptoms, why they matter, what they can indicate, and then from there, they can then be used to further evaluate and to treat. When a woman with chronic hypertension is planning on becoming pregnant, she should switch off of medications such as ACE inhibitors and ARBs because these are not appropriate during pregnancy. She should instead begin treatment with medications that are safe during pregnancy, such as beta blockers and calcium channel blockers. The goal of treatment with these medications is to keep blood pressures below 160s over 110s. And these medications can also be started in women who are newly diagnosed with chronic hypertension during pregnancy. Frequently, it is recommended that these women begin taking a baby aspirin daily late in the first trimester of pregnancy, because evidence has shown that this can help to decrease risk of later developing preeclampsia in the pregnancy. But for those women who do later develop preeclampsia superimposed on top of their chronic hypertension, those women will then be treated in the same way that we would treat other women with preeclampsia, which we will discuss in a couple slides. For women who develop gestational hypertension or preeclampsia without any severe features, expectant management is appropriate. This will include frequent evaluations. So these include twice weekly blood pressure and proteinuria evaluation, weekly lab evaluation, including creatinine, CBC, and liver function enzymes. Fetal surveillance, including non-stress tests, and biophysical profiles are indicated once weekly for those with gestational hypertension and twice weekly for those with preeclampsia without severe features. And finally, fetal growth ultrasounds are indicated at least every 3 to 4 weeks in order to ensure that the fetus is growing appropriately with no intrauterine growth restriction. Delivery is indicated at 37 weeks for these women, or for people who develop either of these conditions past 37 weeks, they should be delivered as soon as diagnosis occurs. Induction of labor is recommended for these patients. C-section is not necessary unless indicated for obstetrical reasons. Delivery is the most curative treatment for any woman who develops gestational hypertension or preeclampsia with or without severe features. However, for women who develop preeclampsia with severe features, delivery is indicated sooner, at 34 weeks of gestation or above. For these women, they will be admitted, induction of labor will be started, and they will be started on a course of magnesium sulfate for seizure protection. These women will also be administered antihypertensive medications by IV push, such as labetalol or hydralazine, in order to bring blood pressures into better ranges. We look to establish ranges of less than 160s over 110s. These women will also be started on PO medications such as labetalol or Procardia in order to really maintain those pressures where they need to be. For the fetus, the woman will be started on a 48-hour course of corticosteroids in order to promote fetal lung development. For women at less than 34 weeks of gestation, once they have completed 48 hours of magnesium sulfate and the 48-hour course of corticosteroids, they may be expectantly managed in the hospital, so long as her blood pressures remain in established rates. However, these women need to be delivered immediately at less than 34 weeks of gestation or whenever she presents, if she presents with any of these severe features listed here on this slide, things such as eclampsia, uncontrollable maternal hypertension that does not come down to the desired levels, even with maximum administration of medications. DIC, pulmonary edema, or any of the other obstetrical considerations listed in this chart. As with any disorder, the best way to help prevent developing hypertensive disorders in pregnancy is to mitigate risk factors that can lead to it in the first place. This is why preconception counseling is so important for a woman who wants to become pregnant, as well as adequate prenatal care during the pregnancy in order to monitor any signs or symptoms that may develop over the course of that time. Unfortunately, many risk factors for these hypertensive disorders in pregnancy are not modifiable and are not in our control. The risk factors that are most common for developing these hypertensive disorders are listed here in this chart. However, the most important risk factor that comes up most frequently is within our ability to control, and that is a high BMI. Women who are able to bring their BMI within a normal range before pregnancy decrease their risk of developing one of these hypertensive disorders during their pregnancy, both because BMI in and of itself increases the risk, but also because a high BMI can also increase risk for developing other issues related to developing these, such as diabetes and chronic hypertension. It's also important to note that if the woman has the luxury of being able to choose when in life she would like to time her pregnancies, doing so may also help to decrease her risk of developing these disorders, because extremes in maternal age below 18 years or above 40 years have also been shown to increase risk of developing one of these hypertensive disorders. So, here are the key take-home points to remember. First, the incidence of these hypertensive disorders of pregnancy are increasing, and that's a huge problem because they account for a very large percentage of the maternal morbidity and mortality in the United States. It's also important to remember that the preeclamptic syndromes are caused by abnormal placentation, because this can help understand why we do what we do and why it helps affect the woman and bring down her blood pressures. When the placenta is implanted inappropriately, it then leads to endothelial damage and a whole cascade of other symptoms that cause problems for the mother and for the fetus. Now, each of these disorders has different signs and symptoms that we look for to help diagnose, and then those various diagnoses then determine how we treat. And we do have a number of different treatment options available for these women: great hypertensive medications and the use of magnesium sulfate for a woman who develops preeclampsia with severe features. However, always remember that the most curative treatment for these disorders is delivery. And so that is why these disorders frequently lead to preterm delivery, which can cause issues for the newborn. And finally, a woman, the biggest thing she can do to help decrease her risk of developing one of these issues is to start her pregnancy within a healthy, normal BMI range. So any woman who comes in for preconception counseling should always be encouraged to get her weight within that range before she becomes pregnant. Doula and birth educator Sharon Musa says, "Birth is a three-legged stool: a healthy mom, a healthy baby, and a healthy birth. Without any one leg, it is equally unstable." And this is why maternal health is so important, because a healthy mom can then go on to care for and raise a healthy baby and a healthy family. For more information on hypertensive disorders of pregnancy, please utilize these resources below. Thank you.